essentially what I want to talk about, as you can see, are interruptions. And I know that this is a very specific aspect of communication, but I think that we can draw a lot of lessons from different industries, including the aviation industry, look at some of the research going on in cognitive psychology, and then hopefully talk about some of the possible implications or potential negative impacts we might have in the emergency department. So I'm hoping that towards the end of this we have a discussion about some of these issues. But certainly if there's any questions as we're going through the topic, please just ask them. Put your hand up, interrupt, and we'll go from there, okay? So our story, I think, really starts with communication. And when we look at the environment that we're in, we tend to communicate quite a lot, right? We have to speak with the patients to obtain our histories and our physicals, get some background information on them. We have to read through PowerChart to get information on other people's communications in paper format so we can understand what's going on. We communicate with the nurses that we work with, they communicate with us, with other healthcare professionals, with consulting services, surgical residents, internists, SMR. All of this it goes on all the time in the emergency department. It's one of the biggest things that we do. And the importance of it is that we use it for all kinds of different aspects of our job. You know, we look at it for updates on patients, information about the patients as they're coming into the department, concerns about patients that may be presented one way, triaged at one level, and then have changed since they've arrived, so on and so forth. Details about the patients that we're dealing with and looking at. Information that we need to help make diagnostic decisions, to obtain our differential diagnosis or generate our differential diagnosis and arrive at an appropriate diagnosis. Decisions that impact on management care and information and communication patterns that impact upon that. And in short, really, our job with communication, and probably one of our most important jobs through all this communication, is that it has a huge impact on patient care. And we'll get into this a little bit further into the discussion, but to sort of start off, I'd really like to just sort of talk a little bit about communication patterns in general, if that's okay. So, you know, what do we do and then how do we communicate in the emergency department? What sort of things are we communicating? Who are we communicating with? To what end? Why are we doing that? And I think we kind of all have some intuitive ideas of how that works or some personal experiences for that. But there actually have been some people who have sat down and studied these patterns and tried to determine what those patterns are and who those patterns are with. And I think that a very nice way that this was laid out was in one study, it generated what's called a link analysis. And a link analysis is essentially a visual representation of the communication patterns between a group of people. And essentially what they would do in these types of studies is an observer would be present, they would watch particular people and sort of observe every communication that they had over every minute, or even less in some cases, and just record who they're communicating with, what the general communication was about. Was it a personal communication, a business communication, those sorts of things. And they generate something like this. So they generated these link analyses, which, you know, I don't expect it to go through all of this in detail, but the point is that here's a visual representation of general emergency department communication patterns. So on the top aspect here, we have the adult emergency department, and the bottom aspect is the pediatric emergency department. And what they've done here is each of these circles represents sort of a different player in the emergency department. So either the attending staff up the top here, you know, an R3, R1s and 2s, the charge nurse, bedside nurses. Same thing through all of these link analyses. And what the patterns show is these lines are sort of connecting them, and the thickness of the line represents, in this case, the percentage of sort of communication events between these people during the study period, right? So you can see, you know, some of the stronger connections are between the nurses and the residents, the attending and the residents, and the charge nurses, and so on. And I think it's kind of an interesting thing to think that during this study in the North American Emergency Department, they found that in the 4 hours for each of these people that they followed them, and they followed 2 of each of them. So a total of 10 people, each for 4 hours. And during that period, when they excluded all of the social and personal communication events that they were having, they had 794 communication events occurring between them just in a 4-hour period. I think that's a pretty impressive number. If you take out all the chit-chat and the social stuff and all the friendly things that we like to talk about, that's a huge number of communication events between people just in the emergency department over a 4-hour period. So I always thought that was kind of an impressive value. So we can say probably at this point that sure, there's lots of communication in the emergency department, and I think most of us are probably aware of that anyways, but it's nice to sort of prove it. I think that if you look at the numbers, there's very small numbers of people for a very short period, and still a huge number of communication events. But then they kind of went a little bit further, and they asked, well, what type of communications are we having? And I think that's even a little bit more interesting, to be honest. So the same type of thing, here's another link analysis. It's set up very similar to the other one. And what this one is showing is the percentage of events based on the type of communication that they were having. So the adult emergency department on the top, pediatric emergency department on the bottom. And essentially the dark lines, the thickness of the lines represent how much was going on. So in this case, this would be the percentage of events that were face-to-face communication between all of these players in the emergency department. And this was the duration of those as a percentage of the time of the study period. So I think that's even a little bit more impressive and important for our talk today about interruptions, in that somewhere on the order of 70 to 90% of our communications in the emerge are face-to-face. Right? They're basically dealing with someone directly. And I think that predisposes us to sort of suggesting then that there's a lot of potential interruptions that are going on in the emergency department, which made me start wondering, what sort of impact could that have? So they looked a little bit further and looked at interruption rates on average during that study period. And they came up with some averages. Now these are the mean from this study. There are other studies that have found different averages, anywhere from 4 to 16 per hour for an attending physician. The range in this study was actually 4 to 15 per hour, but their averages were about 7 per hour for the attendings, about 5 per hour for the R3s. The charge nurses had about 4 per hour, R1s and 2s about 2 per hour, and so on. So they're not the highest ranges from the studies out there, but they certainly suggest that there's a fair amount of your time, each hour in the emergency department is spent dealing just with interruptions. Now you factor that over an 8-hour shift, that means in each shift that you come into, you could be experiencing upwards of 50, 60 interruptions just in the one shift. Another way that you can look at this, and this is from a different study, is you can look at the percentage of tasks that are interrupted. So in this chart here, you have the physicians and the nurses, the number of people they looked at, the hours that they were observed, the total number of interruptions during those hours, and the total number of tasks they were doing during those hours. Then you can break down to the tasks they were accomplishing per hour, and then ask what percentage of those tasks were interrupted. And I think this is kind of an interesting value as well. I think this one is probably a little bit on the high side, to be honest with you, and that probably is based on their definition of interruptions or breaks in task. But if you look at this one, the percentage of tasks interrupted for physicians during the study period was about 25% and about 17% for the nurses. Another study that we can look at, again, takes another little twist on it, doing the same type of thing, an observational study where they're looking what everybody in the emerge is doing, and the physicians and nurses, and watching them carefully and tracking their behavior. And in this one, they look, the number of tasks, number of interruptions, and then they added an additional component, which is number of breaks in task. So when they define this, this refers to a task that they were doing something, were interrupted, and not only did they have to attend to the interruption briefly, they had to then completely switch what they were doing and change what they're doing and go deal with the interruption itself before getting back to what they were doing before the interruption. And on that, and in this case, for a 180-minute study period, they had about 20 breaks in tasks on average, from about 30 interruptions on average during that study period. So it sort of brings up the point that an interruption can be something brief, right? And it may not result in you changing what you're doing. But I think in this study, they kind of nicely show that in many cases it does, and actually about 2/3 of them result in completely changing what you're doing, which I think has significant implications as we'll see as we go through some of the other data. So to sum up the first chunk of the talk today, we can kind of say that we communicate a lot in the emergency department. We can say that interruptions are very, very common. We can say that all players in the emergency department, the nurses, the physicians, the residents, are all involved in these interruptions. And it's just really only one aspect of communication. It's just a small component of the communications that we go through every day in the hospital in general, let alone in the emergency department. So the big question is always, going to be, who cares, right? And I think that's an important question, and it's worth asking, because I know if Carl was here, I'm sure he'd be asking that, and I know Derek is wondering that right now. So those are important questions to answer, and I'm going to try and lay out for you why I think we should care about it, at least a little bit. Part of the reason is I spent about a number of hours going through a number of papers in aviation and cognitive psychology, so I care, at least on that level. But I think we should care about it, and I guess one of the questions and reasons why I think we should care kind of brings in the whole issue of patient errors and adverse events in the hospital. We know that from To Err is Human, that Institute of Medicine study in 2000, in the hospital we know about 10% of hospitalized patients in the United States anyways suffer an adverse event. Half of those are preventable, and so that led to about almost 200,000 deaths annually just due to medical errors. That's a huge number. I mean, that's something that if it's an error, perhaps we can intervene to try and control that. And any way that we can do that, I think, is beneficial to our patients. So we should care about the factors that are causing errors. And what's the number one cause of medical errors?
Cognitive errors?
Cognitive errors? No, it's in there, but communication. Who was that? Nice. So that's correct, right? Communication errors were listed as the number one cause of medical error. And even to the point of saying that communication errors cause twice as many errors as inadequate clinical skill. So that's kind of a reassuring statement for us R1s and 2s as we're trying to sort these things out. But it's important to note that the communication was a huge part of it. Now that's still to say that interruption is still a part of communication. So we don't know how much of those communication errors could be due to interruptions. But it's kind of a question worth asking when you think that you're interrupted 50, 60 times a shift. And as we'll see, those interruptions have a cost on your thinking and your problem solving and your ability to work safely in the emergency department. So this is really what we're going to talk about is the interruptions. In the emerge, we've got this notion that's a natural laboratory of error because it's very busy, very communication driven, lots of interruptions, very dynamic environment, high stakes, fast paced, all sorts of things are going on there at the same time and it changes very quickly. So we could say that do we have any studies that look at environments like that and ask what the effect of an interruption or communication problems could be? And I think that's where it takes us to the flight deck. So aviation has been looking at this issue for a long time, right? Aviation errors are obviously not something that you can hide. Usually whenever there's an accident in the airline industry, it's all over the news, there's pictures of it everywhere. It's a terrible thing. And so this is an industry that for years has tried to figure out how can we study aviation accidents or errors and figure out the causes of them and then put in place strategies to try to mitigate those causes or reduce the effect of problems in the cockpit and getting a plane off the ground. And the reason for that is it's a very high stakes game. You're going to take, thousands and thousands of tons of metal, plastic, glass, combustible fuel, 500, 600 plus people, your kids, and you're going to hurtle them through the air at like several hundred miles per hour. So you don't want to screw things up, because when you screw things up, things go really badly. And that's, something that we need to consider and try to think that these are aviation accidents. What do the pictures of patient accidents potentially look like? We say that the environments are similar between the cockpit and the emerge maybe because they're both dynamic, high stakes, communication driven, lots of interruptions, things change quickly. But there's still a huge difference between our environment and the flight deck. And the difference, I think, or one of the biggest differences, the cockpit is a very, very scripted environment. This is an environment where the pilots have flows, and a flow basically lays out in diagrammatic format how basically a pilot is supposed to work through the various panels in that cockpit in an efficient manner and in the manner that's designed to help reduce them from forgetting something or making a mistake or missing a switch or forgetting to turn the pump on or something like that. Then the next step would be they'll have a checklist for each of those things and each item in their flight takeoff plan. And that checklist can be 50, 60, 70 items long. It'll have multiple points, multiple steps of what they're supposed to do in a very specific order in a visual format so they can tick off or check each item as they go through them to make sure that they don't miss anything so we don't have something like that happening, right? They also do sim training to try and discuss these issues and train pilots how to focus on it, not miss things on their checklists. They have communication training, so they deal with issues of communicating with one another, with the tower, how to think about interruptions, how to avoid them. And they also engage in training to think about how they think, or what their environment is doing to how they're thinking. So it's similar in some ways, but different, and that is probably a little more challenging in our environment because we're running around, I think, with these checklists kind of in our head. You know, we've got multiple patients on the go. We're trying to keep track of each item that we need to do with each of those patients before we decide to either send them home, admit them, or treat them with something. And yet, pilots can make mistakes with a paper checklist in front of them. You know, are we prone to potentially making mistakes just running around with these ideas in our head and hoping that we don't miss anything? We go back to the pilots and ask, what did the Aviation Safety Reporting System and the National Safety Transportation Board have to say after they investigate a lot of these types of accidents? Well, they found that interruptions were frequently played a huge role in aviation accidents, and in a lot of cases it was very significant. The issue of concurrent task management always pops up because they are trying to do a number of things sort of simultaneously. Excuse me. But yet they didn't think that that was the #1 cause of a lot of aviation accidents. They actually found that over half of accidents were due to crew error, and that among those, interruptions and distractions were among the most common reasons for crew error. They felt that pilots were forced to continually interleave novel, unpredictable tasks with well-practiced or habitual tasks. And these caused continuously form and defer intentions and remember to resume suspended activities. And I'm going to harp on that last quote just a little bit. I'm going to repeat it. Continuously form and defer intentions and remember to resume suspended activities. And this is a very important point because this part brings in the aspect of cognitive psychology and why potentially we're at more risk for these interruptions than we think. So we can say that the interruptions, and what we'll find is that it leads to increased cognitive load. It forces you to create what's called a perspective memory, and I'll talk about that more in a second. But essentially that's a memory to come back to the task you're doing at the right place to continue doing it correctly after you've been interrupted, and then resume that task efficiently without making mistakes. At the end of the day, the ASRS and NTSB intentionally said that intentions were not easy to complete. So the intention to complete a task after an interruption was something that people, including their pilots, were not that good at, even with their checklists and flows. They found that even a period of an interruption as short as 15 seconds led to a detriment in performance after the interruptions. And they made some suggestions, and two of the big suggestions they made were, one was that all of their pilots and crew should be aware that interruptions happen and that they're potentially dangerous, and that they should treat all interruptions as red flags. So anytime they're interrupted, they're trained to consider that they have been interrupted, recognize that, and do something to try and put in an extra task to reduce that interruption, or reduce the effect of that interruption. So this is when we start getting into a little more of the cognitive psychology, academic type stuff. And I think it's important to look at it because these guys have been studying this for a long time. Now, the studies that they've been doing are definitely different than what you'd find in aviation and what we could potentially do in the emergency department, because it's very focused. A lot of the effort is spent on exploring particular models of thinking and trying to devise studies to either prove or disprove a particular model, and then try to apply that to a field setting. But there's basically three main models that come into play. And I kind of mention these more to sort of respect the history of some of this cognitive psychology and sort of interruption studies. But the three main models they have are perspective memory, activation-based goal memory, and multiple resource theory. Probably the perspective memory is probably the most applicable one in most cases. But essentially what it says is that an interruption creates a prospective memory task. So some tasks that you have to remember to remind yourself to get back to in the future. And you have to remember to resume that without prompting. Activation-based goal memory will say that your cognition is directed at the most active goal and retrieval at any given time. So basically the amount of activation associated with a memory item is subject to decay. So very quickly it can decay, and you have to constantly refresh it or else you're likely to forget it. And then multiple resource theory looks at a little more of sort of concurrent task management and how we adjust our thinking when we're trying to do a number of different things at the same time or around the same time. Most studies say we can't really multitask, but that's another side point. So I think prospective memory is probably the most useful one for our purposes. And how do they break these down? So in the studies, they'll set up the study participants in a little room. Maybe they'll have 2 computers in front of them, and there'll be separate things. One computer will be blank initially, the other one will have a series of complicated tasks or orders or something that they have to do. And at some point during it, randomly selected, they'll interrupt some of the study participants. And on the second computer, they'll have to attend to something else, and they'll have to do that task before they can get back to the task they're doing before. And then they looked at, in the original task, what sort of mistakes were there happening? Was it taking a lot longer to complete the overall task because of the interruption? How much time occurred between the interruption, starting the interrupted task, and getting back to the original one? So very kind of detailed studies into these types of things. The point really trying to figure out what are the limits of our mind or our human cognition, essentially. And so when you see on this one, this is kind of an example of a sort of an efficiency study. And they'll look where they start the first task. At some point they're interrupted, asked to do something else. There's a period of time before they start the other task. Then they basically have to end that task. There's a period of time before they get back to what they're doing before. If you summarize all these studies, I'm not going to go through all of them because it's going to be very unpleasant for everyone here. But to generalize a little bit, most of the studies, what they generally would find is that your performance after an interruption goes down, that the likelihood of committing an error goes up, that your stress goes up, and we know that stress impedes performance or deteriorates performance, and that your efficiency for completing your tasks goes down sometimes, not all the time. It seems that if you're doing a complex task and you're interrupted, your efficiency goes down. But if you're doing something fairly simple and that is habitual, your efficiency actually goes up. And so an interruption tends to move you along a little bit faster if you're suturing too slowly. And also it varied by the type of task, right? And that's kind of what I was alluding to, that there's procedural tasks, problem-solving tasks, and decision-making tasks. And essentially, these ones are far more affected negatively by interruptions than tasks like this. There's a big difference there. So if you're suturing, an interruption isn't as big of a deal. If you're trying to sort out a potential PE or read a complex ECG, then it becomes a different story, and that you're likely to make more mistakes, and it's likely to take you longer to do all of the things that you're trying to do. And I would argue that a lot of it comes down to cognitive loading. Is this oversimplified? I think so. But if you look at most of it, what is it really saying? Is any time that you really have to focus, you have to increase your cognitive load for whatever task that you're doing, interruptions can have a negative impact on you. And it tends to be worse if it's a complex task. Okay, so we're not at the end yet, but we've jumped around a little bit. We kind of looked a little bit at communication patterns in the emergency department in general. Recognize that a lot of it's face-to-face, we have lots of communications, and we get interrupted a lot. We learned from the flight deck that communication is a big part of errors, and that interruptions are a large component of that, and they recognize that in the industry and actively work to reduce those. And then we looked at some of the findings from cognitive psychology that suggests that interruptions may cause more problems than we potentially realize or appreciate. Are there questions about anything at this point? Yeah, I don't know.
Did you read anywhere when interruptions are good? And there's a lot of push from Institute of Medicine that we should be interrupted more often, especially when someone around us on our team recognizes that we may be making an error, potentially making an error. And that's why we should welcome comments from members of the team.
I think that's an important thing, and I was going to get to that in the next part, because essentially I'd agree, right? An interruption is not something we want to get rid of, right? But really there's kind of two types of interruptions. There's the interruption that, hey, you're about to give the wrong drug or the wrong dose. There's the interruption that that patient in, RAS, his blood pressure is now 60, systolic. And then there's an interruption that, hey, can you sign this form so I can send this patient home? So there's different types of interruptions. We can't get rid of them all. I think what I'm trying to get at today is we've got to recognize that, interruptions can have a negative impact, and we do have to evaluate the importance of what we're interrupting somebody for in order to determine whether we need to do it right now or we can hold off a little bit so that potentially we're not interrupting someone when they're very busy with something or thinking about something that might have a detrimental impact in the long run.
Sean, you made a comment about stress being detrimental.
Yes.
Did you want to qualify that a little bit? Because
yeah.
Again, along the same lines as what Adam's talking about, some stress surely helps us move faster, focus better. It's when stress gets out of hand that perhaps it's detrimental to the task at hand.
If it gets to the point where it's high, the trouble is we know that negative affective states or stress or negative emotions, those types of things, when you're trying to make decisions, can actually negatively impact your decision making. And that's kind of what they're alluding to in a lot of the studies, is that generally people, when stress levels get very high, tend to make poorer decisions or make more mistakes. So you have to think that if interruptions increase stress, there's going to be a threshold at which it goes beyond just acceptable interruption and one that you can tolerate well to something a little bit too far, where now it's starting to have a negative impact upon you.
I'm going to be touching on CRM, like resource management, in terms of interruptions. So I think that's what Adam's alluding to, and that if you look at the aviation disasters, about 80% of them actually someone on board had the information to mitigate that disaster or prevent it, but they felt not empowered enough to communicate that back. So,
Right.
So we look at adopting those lessons to medicine. We see that all the time in the emergency department when you have one of your nursing colleagues sees an order that a house staff person has written, and then they circumvent that by bringing it back to the staff person or a different team member and saying, look, I'm concerned about this, and they bring it forward in that regard because maybe they don't feel comfortable speaking directly to that individual who wrote that. But that's the sort of the healthy interventions, and formulating a method by which you can communicate to people on the team at an equal level is a very important thing, and that's what CRM teaches you, is that you can actually speak to the pilot and speak to the first officer if you have information about it, but it has to be in a certain format.
I didn't look at that specifically, but that's a very interesting topic that I'll have to look into now. So, I tried to tie this into some of our more recent sort of theories about thinking in emergency medicine and those types of things. We don't have a lot of data linking interruptions directly to medical errors, and as Adam and Mike were pointing out, there are cases where we want interruptions and they actually help and help prevent errors. But we're kind of looking at the negative side of them today. So, but we can certainly extrapolate from some of the research that we've looked at in other industries and other fields and sort of say what are the potential implications to us. So we've kind of stated that our environment is a very dynamic, communication-driven environment. Interruptions are everywhere, and they're not all bad, right? And that's kind of, you know, you're a couple slides ahead of me, but they're not all bad. We want them, right? In many cases, they're good. They prevent an error. They may inform us about a patient we need to know about when we may not be paying attention to it. So I think, you know, the thing is, there's lots of questions about this now. So, you know, what sort of things can we say about it? I'm not sure. What sort of risks are there? There potentially could be a lot of risks. There could be a lot of benefits. Can it increase our error rates? In some cases. Can it decrease them in other cases? Sure. So should we be thinking about it, and why should we be doing that? So can we apply some of what we've learned in other areas in our current thinking in emergency medicine to research and theories? And there are some studies, you know, there's nursing studies, there's pharmacy studies, anesthesia. They've looked at these issues and asked, in nursing and pharmacy, they found that, you know, interruptions during medication administration can lead to increased errors. So, and in many cases, the number of interruptions as they increased the likelihood of an error occurring. Now, that isn't looking at the cases where an interruption catches an error, but generally, if you're having someone put together medications and dosages without an interruption and they can focus, they generally do that better and safer than if they're not. Pharmacy has found similar results. Anesthesia has looked at a little bit of this in the OR, asking, you know, did they forget to do certain steps in the intubation or putting a patient to sleep for surgery? And they found that error interruptions do increase that risk a little bit, as well as potentially increase the time it takes to get the person ready for the surgery. So maybe we should be asking, does it impact our thinking? And should we be thinking about how interruptions impact our thinking? You know, so should we be thinking about how we think? And I don't think anybody thinks about how we think more than this guy. And I'm sure somebody knows who this is. Yeah, so of course. So Adam Crosscarry is, you know, he's a researcher from Dalhousie, emergency physician, and he's done a lot of study into the whole issue of cognitive error and looked at the things that cause us to make mistakes. And, you know, I say that in some of these areas, communication is a big part of that. But his main approach is this dual process theory and dividing up how we think into two main methods of thinking. We have sort of type 1 and type 2 thinking. The type 1 tends to be more simplistic, heuristic, pattern-based, experience-based, faster, but maybe a little more prone to error, versus the type 2, which tends to be a little more analytical, more step-by-step, a little less simplistic and certainly a little less prone to errors. And that we kind of, the argument is that we kind of switch between these two different types of thinking based on the case before us, our stage of training and experience, and various other things. And I would say if we look at some of this though and go back to the cognitive psychology issue and the demand that a task has on our cognition, maybe we could say that interruptions can interfere with that thinking. And maybe in cases where interruptions are high and your stress levels are getting higher and distractions are getting higher, that you tend to switch more to a type 1 versus a type 2 type of thinking to sort of offset that sort of cognitive demand that's coming from your environment. And then that may be a situation where you're using type 1 where you shouldn't be using a type 1 approach to thinking. So maybe if you increase all of these things, increase interruptions, distractions, and stress, maybe you're sort of running the risk of making decision-making errors and problem-solving errors that can impact our patients. So in short, could we potentially increase errors for our patients? So I guess if we think the risk is real, what can we do about it? And I'm kind of getting to wrapping up at the end where I want to hopefully get into a discussion about this. But I think probably the most important thing is we don't have the answers to this yet, right? It's something that we're looking into and we're exploring. And I think it's something that if we're aware of it, that's kind of the first step, aware of the potential risks of an interruption as well as the benefits, and sort of try to evaluate what is my role as a person interrupting someone or as a person being interrupted, and how might that affect me or that other person. And maybe try to come up with some strategies that in cases where you do need to attend to it, you're not forgetting your task afterwards or making a mistake when you get back to what you're originally doing. So, I guess the question is, do we think the risk is real or not? And then if we do, what types of things do you think we can do or should we consider in the department when we're working? And that's like
I'll comment because it's just kind of hitting home with me, because I think we need to encourage more communication than we have currently and encourage more interruptions. And I've heard recently from a number of different people that some of our staff and residents aren't approachable by other members of the team and frankly discourage interruptions, which is, I think, kind of, or is definitely detrimental to patient care. So I'd rather we breed a culture of encouraging more communication and more interruptions, but be aware of the effects of those interruptions on our thinking so that we can reset the task.
Yeah, I think though it's sort of getting into different aspects of things too though. It's more about communication and being not afraid to go talk to someone who may be more senior than you. I don't know if that's really necessarily specifically an interruption per se, but I
think our days are so full in a shift, especially as an attending physician, that no matter when you talk to us, you're almost always interrupting.
Yeah.
I would argue. There's really very little downtime.
I would say though, I think we're talking about two different types of interruptions. I agree that enhancing communication and team communication is beneficial to patient outcomes and patient care. So if somebody notices that a drug order is written incorrectly, and they feed that back to a member of the team, no matter who that is, resident, staff, and then the team can act on that and then reflect on the fact that there was almost an error made. I think that's an important type of interruption. I think the more concerning type of interruption is an interruption that has nothing to do with the task that you're currently doing. So I use the example of asking a staff physician to interpret an electrocardiogram in the emergency department, which is becoming more and more common as we do more and more ECGs at triage, and that the nurse at triage or whoever's done that ECG presents that electrocardiogram to whatever physician they can essentially run into first. So I would argue from this data that it's the physician who's doing the simplest task, so a physician who's assigned to Unit 45, for example, who would interpret that electrocardiogram and then be able to return to the task that they were doing, and maybe, according to this data, be even more efficient at doing the task that they were doing, instead of bringing it to the person who happens to be in Pod A, reviewing cases with house staff, when those cases may be CTAS 1s or CTAS 2 patients. I think that's extremely detrimental. So I think what we need to be thinking about is batching the types of interruptions that we do and using them based on this literature if we believe that it has an effect on patient care, so that we're enhancing overall physician performance and trying to get away from interruptions that are going to be detrimental to getting you back to that task, particularly if the task is very complex, where you're going to have difficulty reinitiating the cognitive thought process to follow through with what you started to do.
And you,
So I
you can
think that's
have
the
a
difference.
planned value to that interruption. So an ECG from triage that isn't an acute STEMI has a value per se.
Correct.
That you're asking the nurse to judge somewhat, but most of them are normal. So you assign that to a certain physician who might be doing less complicated tasks.
Correct.
A medication error has a value to it because we know that's potentially a big error. Most of our interruptions, or a lot of our interruptions, are in the middle. I think we need to be open that all of us, or at least someone on the team, is open to being interrupted by something that we cannot expect other members of the team to judge the value of. And that's why they're bringing it to us.
Right. But I would say that just by virtue of thinking about this process of cognitive error and what we do every day in an increasingly busy, task-oriented, multiple decision-making, simultaneous environment, I think is something that we all need to think about when it comes to decreasing our error rate, you know, making sure that patient safety is enhanced and making sure that our productivity is as good as it can be.
Just to add to that, I think just to what you just said, Karen, I mean, I think what you're touching on is having specific tasks allocated to physicians who are working in different areas of the
Yes.
department or who are currently doing other specific tasks. Sometimes what happens is that there's one of 4 physicians is very approachable and the other 3 are not. And so nursing staff will tend to go to the one physician with everything.
Lots of nodding going on.
So that's what we need to change, try to work on changing that culture.
Right.
And as you suggested, perhaps the Unit 45 doc is the right person for the ECGs, but maybe that's not the right person to do some other task, follow up of the labs on LAMA patients, for instance. And some of those things can be slotted into specific times.
Right.
Other things, in order to keep the department functioning well, you can't necessarily ask everybody else to wait just because you're sort of thinking about something. Clearly, you shouldn't be interrupting a complex thought process, which for some of us is all the time, of course. But no, we should think very carefully about who we're assigning tasks to and which tasks, and it probably should be area
Specific.
prescribed or whatever.
Yeah, and that, I mean, Sean and I had a detailed conversation about this when we were preparing these rounds, and I think it involves a change in just the culture of how we communicate and how we see interruptions and the impact of those interruptions into our emerge environment. Another example would be how well we've developed the system of laboratory callbacks or discrepancies for x-rays and assigning that to a particular physician. The information is batched, put in a specific area. We know that that's a task when you're on that shift. Whereas before we had that system, those were constant interruptions. Follow up on this urine culture, for example, which could happen at any time during your shift. But we've done things to really improve some of the more menial tasks, but require follow up, for the benefit of patients in the emerge. But yet, when we're actually in the middle of a shift, and we have things that happen in real time, like ECG interpretation, for example, we still don't do that very well.
I spent a lot of time thinking about this since last year. I took the patient safety officer course and really spent a lot of time focusing on how I make decisions and what frustrates me in the department. And this is my personal frustration. And you try and think of why am I becoming frustrated right now? And it's because you're being pulled in different directions. And then I force myself to sort of back up a little bit and try and think of what could have been different about this. And I think that what Adam's point potentially could be as well, and what Karen is saying, is that potentially we could also have a threshold by which certain things are absolutely are imperative to interrupt the nearest physician. Like there's a medication error, there's someone arresting, there's something absolutely imperative. It doesn't matter what you're doing, this trumps that, this needs to happen. So it's sort of in an aviation instinct, like confirm you see these wires. So this is true. You are not. You're never allowed to speak to the pilot in the back of the helicopter during takeoff and landing on final approach. You go to the dark cabin. But as soon as if you see something, you're allowed to actually say, but you just phrase it with this. So I think that those are uninterrupted. No questions asked. You can't interrupt us for that. That trumps everything. But I find it's the third interruption that gets me. So I'll be talking to a house staff about a case, The phone ring will be radiology, there's no problem. I'm looking at the nurse in the corner of my eye, I was waiting with an ECG to review with me, and then all of a sudden something else happens, and I'm like, that's it. Okay, I'm here right now. Or I'm trying to make the pod B, and I'm on my way, and then the psych nurse interrupts me, someone else gets me, and I'm like, okay, I got this, and then in the back of my head, the medicine resident that I just referred that person to says, can you make sure you add the urine electrolytes to this? And I'm like, sure, I'll do that. And then there's the fourth thing that gets me, and then I'll never remember to order those urine electrolytes, whatever it is. So these are the small gaps that we have, not that it matters, but these are the, maybe that's a repeat enzyme, or maybe that's a repeat the cardiogram, or it's these things that fall, you'd be driving home and you remember that I never did order that, or I never did get that, and things get slipped through the cracks. So I think, so my solution to this would be that I think that we need to understand that there may be moments in our daily lives where we need to create a threshold by which it seems reasonable to interrupt, and also maybe we have dark periods where that physician is reviewing a case here in Pod A, and maybe now is not the time to bring this less important task to them, because you do get frustrated, and then also even just the fact that you know someone's watching and waiting to bring you something else, you may actually shorten your interaction with that house staff. So what I've done now, and this is just my own approach to this, is I realize that I'm going to pressure that house staff member to minimize their review of this case so I can get to this task. And then I may miss a critical piece of information, and then just to be able to get to the next task, which is easy. So I stop what they're doing, I do the easy task and get out and then go back to what I was doing. But maybe that should be one of the blackout periods, like landing and takeoff, where we should really talk to that physician about this low threshold thing and go on and bring that to someone in 45.
Like, I think, you can't get rid of them, nor do we want to, right? So part of this isn't really to say that we need to get rid of all interruptions in the emergency department, but exactly what you're talking about is, maybe raise more awareness of the potential risks of those, and then put in your own strategies or strategies that others have tried to sort of minimize any negative consequences of them, just like as you described right there. I think it's a perfect example.
Another example is research we need to look at, because we're all looking at physicians getting interrupted, because we do, but there's also 4 nurses get interrupted an hour, things like that. And we think about blackout periods then, because a lot of times there is a perseverance around the doctors themselves that whether they're going to say is that the most important thing and needs to be said right now, and it could be quite trivial. So interrupting someone while they're making meds and things like that needs to be considered. I don't know if we consider enough on our side as well. So I think as much as we discuss prioritizing what comes to the physician at what time, it's also prioritizing when can an order be dropped in the red box versus when you have to tell someone this order needs to be done now. And I don't find we're great at either side saying, can you acknowledge this order because these are antibiotics for a septic patient, versus this is Tylenol for someone with a headache who can probably wait. So I think that needs to be looked at on that flip side as well. It's not just us who get interrupted. We interrupt people like nothing else.
Sean?
Sorry. I'd be interested, I think Lisa's working on doing some research on this right now, but for me personally, I find one of the hardest things is the number of trainees you have. And it's not that I don't like having trainees. I mean, I have junior medical students that have just supervised for clinical methods saying, can I come too? And I kind of think the more people you have that you have in terms of trainees, I find the number of interruptions just inherently goes up. And I always wonder, am I more efficient because I have more trainees because, of course, more patients are sort of being seen simultaneously? Or am I less efficient because I find that my thought processes can't really function in a straight line? I just feel like, you just, like more like Mike was saying, you just turn around and there's someone there and you can't kind of even finish the one that you were just partway through. And so I think that'll be an interesting thing to find out how does it, or if someone's looking into that in terms of the number of trainees and how that affects things, and how it would be different to potentially practice in a center where it was a non-teaching center, and would that affect the number of interruptions?
The data from the P4R project I'm working on will list out as a group and as an individual your efficiency with 0 learners, 1 learner, 2 learners, and 3 learners assigned to you. And that'll be available around the holidays.
You might be more efficient in the end, though, as I was saying, in terms of numbers.
Yeah.
But is the quality?
Of course, and there's no quality
like
measure with that. But
it's confusing. I kind of feel like sometimes I'm seeing more people when I have more learners, but I feel like it's more fragmented and disjointed sometimes.
we'll have an answer to the efficiency part, but not the quality.
And that might vary depending on the level of training of the learner that's with you too, right? Yeah, yeah. And
Laura, I think that's a really important point. Not only the number of learners and the level of the learners, but also what are the cases that you're dealing with at the time. So there's some suggestion that if we're dealing with, if we have 11 patients that we're currently working with, but 6 of them are elderly with abdominal pain, and you get interrupted and you're trying to keep those patients straight, that becomes more and more and more difficult. And nobody actually knows the number of interruptions before sort of, you're, like Mike described, your red light goes off and says, okay, now I just can't remember what I was going to do. So I think that's the type of tasks that you're doing, the kinds of patients that you're seeing in the emergent environment, but also the time of day. So one would assume that when we're increasingly fatigued in disadvantaged hours over the night, when you've done a great number of shifts in a row, those kinds of things will likely impact how well you deal with interruptions as well. And right now there's no data, certainly not in the emergency medicine literature, to look at that.
This is a communication issue, and I'm trying to figure out how we can dig from this and blend this into a different practice in the department. And I mean, you think about our personal communications on a regular basis, you get shocked when all of a sudden your phone rings these days because like everyone texts you or BBMs you or emails you, and you're like, so if the phone rings, it's got to be something emergent. And then you're frustrated when you're like, I can't believe you called me for this. Like, this is so not. And yet, but then you could have emailed me this to me, and then your pager goes off. You're like, I can't believe you paged me to take part in this survey. Like that would be asinine to do that. Yet that's what you find communications in the department becomes. You're like, I can't believe you interrupted me. I'm talking about how we're going to resuscitate, how we're going to invoke the massive transfusion pathway for this rupture AAA, and you want to talk to me about this. Like, so I think that at some level we may want to invoke a method by which we can help prioritize interruptions. And I don't know necessarily how to do that, but there may be someone who can be assigned the task of being the liaison officer, or maybe there is some method by which we can filter through a central person, like the charge nurse all of a sudden becomes, like there are nursing concerns, they come to the charge nurse, and the charge nurse can filter those and say, okay, you know what, talk to that guy about that, that he needs to understand, she or she needs to understand that, versus let's hold that right now, and I'll bring this to that person in a minute or two. You almost wonder if there's a method by which we can prioritize our interruptions, and I think that that's similar like we do with our personal communication every day.
I think we could take it one step further too. Some physicians are excellent at delineating the plan for the patient. Other physicians don't communicate it. If you want to, say, repeat these enzymes, if they're negative, discharge the patient home. Lots of times physicians do that, as opposed to me or another nurse having to go back saying, enzymes have been done for 2 hours, repeated negative. If you had simply written discharge home, if enzymes were negative, and something, it would expedite as well, and I wouldn't have to interrupt you to come and say, could you please reassess this patient and discharge them. So things like that as well might help. Some physicians are awesome at it, other physicians not so good.
They may not be laid out as an expectation either.
No.
Usually when I see a patient, I try and say, my plan with this person is going to be this, we're
Yes.
going to do this, but then that may be that individual nurse who's on wide load, I love that term.
Yeah.
But then on break it could be someone else, so you just don't get that communication handed over. And maybe that also as physicians, I don't know if that's been laid out as an expectation of us, that we communicate what our eventual plan with the patients are.
A lot of times we don't know as
We may not know it.
No.
And this does go both ways, right? I mean, we interrupt nurses as much as they interrupt us. Like, it's just part of emergency medicine. So I'm concerned that we're thinking that you shouldn't talk about things and communicate. That's not what my point to this topic is. So, certainly communication is strongly encouraged because it's really important to us. But
one of the things that's come out of the focus groups I've done with the nurses on the P4R project, as well as some of the physicians, is that the nurses would like to have that communication up front about every single patient verbally, as opposed to the orders just being thrown in the box. And apparently that happens like more than 50% of the time. We just throw the orders in the box and walk away and don't tell the nurse what the plan is. It's looking after the patient. And there's lots of reasons for that. Sometimes it's hard to find the nurses. Sometimes they're busy doing a million other things. We don't want to interrupt them. But in general, that's the desire that I'm hearing from the charge nurses and the other nursing staff. Mm-hmm. Also, there's been some suggestions from both the docs and the nurses that we do assign tasks like the ECGs, like the callback boxes to specific physicians, and even maybe go as far as having a physician in charge that some of those communications go through depending on what shift you're working. So all these ideas are going to essentially, hopefully, come out in a sort of recommendation report in the next 6 weeks.
I
think one of the things that's interesting as a learner is also like how much of this gets fed back directly to your staff and how much gets fed back to the house staff looking after the patient. Because I think sometimes like probably our staff are interrupted about tasks that we could, like, or there's a medication error, or the nurses don't feel comfortable approaching the resident, or they think it's important, so they tell the staff. But sometimes, like, the residents could deal with it, and sometimes not. And sometimes we don't actually get the direct feedback on errors that we're potentially making because it goes to the staff, and then the staff says, oh, by the way, I changed this thing for your patient because they caught me. So I wonder if the staff have any ideas about that, and if that potentially could change the amount of times the staff are interrupted.
I would say that, speaking on behalf of, I'm sure, most of the nurses, that we would feel much more comfortable talking to you as house staff than we would talking to some of the consultants that are on. We rarely have any communication breakdowns with you guys. And it's just, it's hard to bring something that you were told from your leadership that you need to have a doctor check this, even though everything in you, all your training, all of your preparation tells you there's nothing wrong with this ECG or there, whatever, and I have to go and ask a doctor, can you please look at this, and then they berate you, you know?
But that's what's written in the directive.
Right. It is a directive. We have to do it, but they're like, I don't believe in this. I think this is a stupid thing, and this is a waste of my time. You know?
I think it's a stupid thing, and it's a waste of my time as well.
Yeah.
Right.
But
you
we
do
have,
get,
it's a safety thing.
You do get that from some physicians where you feel like I've just interrupted you and I, you know, you're belittling me for doing a task that you've assigned to me.
I was actually the opposite. I thought you guys saw me in the car gun that I'm not picking up. I don't see it. You didn't take your message.
I think Kate's point is important though on another level, not just from a communication standpoint, but you know, if a house staff writes an order, I think it's very important if there needs to be clarification or correction to that order, then that information is communicated directly back to the person who wrote the error, because that's a very powerful educational tool. If that has to come to the staff, and then the staff is busy multitasking multiple other things, and may actually forget to actually provide that feedback back to the house staff, then that's a learning opportunity, good, powerful educational moment that's missed in the emergency department, which often happens depending on how busy we all are.
Sometimes the nurses don't know to tell the staff, right, the house staff, and they don't know their level of training. Like, they probably know our emerge residents, but they're not going to necessarily know, you know, how this R1 is. Do they know what they're doing, or do they not? You know what I'm saying?
Is this your patient?
Yeah.
Looking for someone that's helping with that patient.
Yeah.
I think Morgan's had her hand up here for about 10 minutes.
I don't know. I'm thinking about just sort of we keep talking about the ECG situation, and I know that I think a lot of us maybe sort of naturally now when we're presenting to a staff about something, we try and put it into context for them, so that rather than coming up and saying, can you look at this ECG, saying, I have a hypertensive patient who's tachycardic, and this is their ECG, versus, you know, I have a stable patient at triage who looks well, when you have a moment, can you look at his ECG, so that they're not sort of left with a very blanket statement, can you look at this ECG, and have multiple questions that are left unaddressed. And I don't know where, sort of just being a little bit more definitive in how you're doing your interruption and how you're sort of phrasing things, that might help, I don't know, for the staff so that they can sort of prioritize in their mind.
That's a really good point, because one of my frustrations with the ECG, I don't mind reading them, but if I just get the ECG and I don't know, I mean, for me, the age of the patient, if you just tell me the age of the patient and their symptom, chest pain, 75 years old, I look at it very differently than 22, short of breath, or, you know, with a sore big toe, or whatever it is. I still look at it, I still have to do the same task, but I need that additional information personally in order to be able to do that. So maybe that's something that would help diffuse the, you know, the anger or the, yeah.
Is he age on the cardiogram?
Is that?
Is he age on the cardiogram?
60.
My eyes are sorry. No, I'm serious. It takes an extra couple of seconds, and it's frustrating when somebody, while you're looking, can actually communicate that information to you. Sure, yes, it's there, but the complaint's not there. I have another point, and that's with regard to the type of interruption the importance of the interruption, and one of the things that I use that I'm not sure how effective it is, but I think it's effective, is I will sometimes stop what I'm doing, and particularly when it's a nurse who's standing waiting to talk to me, say, is there something important right this second? And I get a yes or a no. If it's a yes, then I take the nurse at his or her word and listen to whatever it is. If it's a no, then I say, okay, I'm just going to finish this, and then I'll try to remember to come back to you. And I probably don't always come back, but what I'm trying to do is to quickly, just a 5-second break that I may not lose my train of thought with everything that the house staff is just telling me. And then I can keep going with that and then deal with the other task later. So I'm trying to pigeonhole it, and what did you call that? That something memory? That prospective memory, that I have that other task to do, to talk to the nurse, but I'm hopefully not interrupting my train of thought and my ability to listen to the story.
Yeah. Because the longer you're trying to hold on to that, particularly as you hit around the 15-second mark, the more likely to forget what you're doing before. So if you keep it really short, you're more likely to get back to it without making a mistake. I think Matt, no?
Sorry, Audrey, for belittling you all the time.
Yeah.
I'm more of a comment for the residents. I think my transition from residency to staff, this was the biggest change I noticed, was the amount of interruptions that do occur. And that's probably been the most difficult thing for me to adjust to as a new staff. And more of a comment for the senior residents, when you're in your R5 year, like, what do you want to do today on your shift, run the department? And I said, yeah, I want to be running the department. And the odd time people would come up to you, but it was night and day from June 30th to July 1st, how many times people come up, all the things that you didn't realize were happening behind the scenes. Like, look at this ECG, this script got faxed back, the clerk's coming up to you, 2 house staff on, so kind of the R5s and the 2+1, you're getting towards that end. Like, go to the charge nurse, say, come to me with everything, tell the clerks, come to me with the scripts, and get a real feel for what it's going to be like, because I think that's been the biggest adjustment.
Because you can't get rid of it, right? And I like what we're saying, we don't want to, but we can try and learn strategies to deal with it effectively, recognize some of the problems that can arise with them, and then try to deal with that so that you don't make a mistake.
And I'm one of the non-approachable ones, so
I think, Adam, did you have one more point? Or
Things like the ECG, there's other ways of dealing with them. If the hospital, for lack of a better term, would get off the wall and spend the money to train the nurses to say important ECG, not important ECG, and professional practice would support them, we wouldn't have to look at all the ECGs. So because we've gone away from training our triage nurses enough that the professional practice is confident in doing that, that's why we're being shown all these ECGs. So we could get rid of those interruptions if we spent the money. So we could make this the case where we shouldn't be being interrupted with this. Let's spend the money to train the nurses up and get rid of the interruption entirely.
Because most of us feel like a pain in the ass when
Yeah.
we have to come.
So there's lots of ways, you just have to look at the particular problem and deal with it.
But today's a lot more than just these ECGs. Today's about like
Of course,
other
yes,
this-
but you can start pulling away little things. Right?
we haven't got into the ECG bit, but I think it's because it's a common one, right? Yeah, it's a very good example. So, and that's why it comes up all the time. But anyways, I think we're probably going to have to wrap it up. I appreciate the discussion, which is kind of one of the biggest goals I was going for, because I think it's a really cool topic. There's not a lot we know about it. And as you know, we realize they're not all bad and not all good. I took the negative side because I figured it might upset a few people and maybe generate some more discussion. But really, I think the issue is just about bringing some awareness to the topic, and something that, you know, when you go on your shift the next time, or you go off service on Access or CCU or ICU, whatever it is, and the pager's going off all the time, you know, just to think about it and sort of maybe keep a tally of how many times you're interrupted and what you're interrupted for and those types of things, and think about what effect that might have had on you and what you did afterwards. Anyways, that's it. Thank you so much.